Greetings of the day, wherever you all are watching this conversation on COVID-19. We have now seen the pandemic extend for more than a year, but the experiences of different countries have been somewhat different and varied. However, a global threat of this magnitude requires a global trust, which has to bring together the knowledge and experience from all parts of the world. So we now have two renowned experts on COVID care and management from India and the UK to discuss how this expertise can be shared between countries for the benefit of all of humanity. We have Professor Randeep Guleria, the Director of the All India Institute of Medical Sciences, and we have Professor Nicholas Hart from the King's College, London. I'm Srinath Reddy, President of the Public Health Foundation of India, bringing you this conversation between these two experts. Well, even though we are now grappling with some of the issues related to saving lives in hospitals, we need to begin at the very first place with prevention. How do we actually ensure that we have enough personal protection measures as well as public health actions that can reduce the transmission of the virus and have effective prevention and control of infection? Professor Hart, what's your experience in the UK of what has worked and what the world should learn from?
Srinath, thank you. And thank you to Randeep as well. And obviously the All India Institute of Medical Sciences for the opportunity to have this discussion, which I think is essential. There's no doubt the UK government has had a very strong approach to the whole idea of prevention. And prevention is the direction that we must go in any ways that when we have viruses of this magnitude. There's been some easy messages from the UK government, and that was hands, face, and space. We need to wash our hands, we need to wear a mask and keep our distance. What came very apparent to us, and I'm sure you've seen this, is the hospital is actually your safest place in terms of infection disease spread. Where we had most of our problems was outside the hospital with people non-adherent to the rules. And so a lot of work had to be done over the whole process of making sure we washed our hands, we wore a mask, and we kept social distance.
Thank you. Professor Guleria, there's a lot of talk about ventilation now with aerosol spread having to be prevented as well. So what's been the Indian experience and how are we revising the guidelines now?
So I think the Indian experience is also focused on prevention as being the key strategy, because unless you are able to prevent the increasing number of cases, you will not be able to provide quality healthcare, and you will have a whole issue in terms of the number of cases, the need for beds, the need for oxygen, and for other supportive treatment. And therefore, from the very beginning, as has been said by Nick also, the focus has been on three main things: wear your mask, keep physical distancing, and wash your hands. And this has been something which has been promoted in all languages in our country. And it worked very well in the beginning. Now, with the fear of the aerosol transmission, ventilation and maintaining good ventilation has also become an important issue, especially when we're looking at the indoor environment. And therefore, advising people to keep the windows open or have a good cross ventilation is also something that is very, very important. But I think one thing that I'd like to stress is that we also need to look at what I would call is a behavioral change. When we had the first wave, the adherence to these COVID appropriate behavior, as we call it here, was much more stronger and much better. But during this time, once the first wave came down, there seems to be a lot of, let's say, frustration or desire to really go out and party and do things like that, which has contributed to some extent to the huge number of cases that we're seeing in the second wave as compared to the first. So there has been also a little bit of a behavioral change in society as far as India is concerned, which has contributed to the increasing number of cases, obviously linked with a more infectious variant.
Thank you. And of course, preventing the large crowded super spreader events, that becomes very critical as well. Now, many of the people are being advised, if they do fall ill but are not desperately sick, to stay at home and to be provided care at home, so that hospitals are not unnecessarily overcrowded. And they can actually, in the hospitals, attend to people who really need intensive care or very closely supervised care. So what are the guidelines that you have for home management in the UK, Professor Hart?
So this disease, as we know, has three forms: a mild, moderate, and severe form. And indeed, we have to think through how we treat these. But if we break it down even further, we actually talk about a home, hospital, and a critical care disease. And I think that's a much easier way to comprehend, in fact, where we get our treatment. The home management within the UK is very clear. You stay inside, and that has to be paramount. The test and tracing to reduce the spread of the virus, because we know you are most likely to spread the virus to somebody else just before your symptoms arrive and at that early stage. So making sure that you isolate immediately is key once you have a positive test. The other parts to treatment within the UK are very symptom-based. Paracetamol, brufen, plenty of fluids. Monitoring your own self in terms of your symptoms has been key. There hasn't been any significant treatment breakthroughs in terms of evidence-based medicine to allow us to go down a road that would suggest there were treatments available currently. There are a few emerging treatments, but these are no way level where we could say they were effective in prevention of admission in terms of patients who contract COVID-19. So supportive care in terms of fluids, control the temperature with paracetamol and brufen, and rest.
Professor Guleria, the All India Institute of Medicine and Medical Sciences has been guiding the country through treatment protocols and also home care protocols. So what is the message here in terms of how best home care can be provided with safety and surety of early recovery?
I think, as has been already said, the most important thing to remember is that home care becomes very, very important, because majority of patients will have a mild self-limiting illness. And we need to do two things. One is limit this sort of transmission of disease, so keep them at home, and at the same time, just give supportive treatment, and they will tend to recover most of the time. So the first thing that we really do is, whenever we have anyone who's tested positive, there is an evaluation done in terms of whether the individual can have home isolation or not. Now, things are slightly different in India. You may have people who are more than one people living in a small room, and you may not have someone who could isolate himself at home all alone, and the chance of transmitting the infection to the other family members becomes much more. Because of that, we started what we call COVID care centers. These are centers which are for those people who cannot isolate themselves at home, and they are providing care for these individuals in a manner they would do at home in terms of supportive treatment, and either a call center calling them up or a doctor being there to just monitor things like fever, saturation, any other warning signs, morning, evening, giving them a chart to maintain, and that can be done. Those who can stay at home, they are usually called twice a day at least to really find out what the temperature is, what is the saturation. Everyone is given a small pulse oximeter to take home. And in India, there is a slight variation that we do advise some drugs. Many of the antivirals are used in India. One which is there is ivermectin, favipiravir is also used, although there is no strong evidence that they are of much use And by and large, what is really working is just supportive treatment in most of these cases.
While home care works for many people, there must be some red flags which we must recognize as to when people must be transferred for hospitalized observation and care. And even in the hospital, there will be some red flags as to when people will require intensive care. Professor Guleria, what are those red flags?
So when we have people who are in home isolation, the first thing that we ask them to monitor very closely is their oxygen saturation. At times, we also teach them about what we call conscious proning, because sometimes that helps to improve the oxygen saturation. But if your saturation is low, and we keep a buffer, so if it's 93 or less, then we become a little bit more cautious and we start monitoring it more closely. If it's closer to 90 or less than 90, we would ask them to come into the hospital and get admitted. If they have any other symptoms which are atypical in the form of chest pain, not able to breathe, or they're feeling very breathless, or they are having some degree of drowsiness, or the fever has become much higher, that they were having a fever which had come down, and on the 7th, 8th day, the fever again starts shooting up to 102, 103, then we are a little bit worried, and then also we would like to get them in. The other thing that we really keep in mind when we ask people who are at home isolation to monitor is for comorbidities. Many of these individuals, the diabetes, blood sugar may go up, and that becomes another important thing to keep in mind. And sometimes if you're an elderly person, then your fluid intake and your, let's say, drowsiness or delirium also becomes something that is important to monitor. So these are things that one tends to monitor. Sometimes we would ask the patient to walk for a few minutes and see whether there's a fall in saturation if you're not very sure how he's doing in terms of his oxygen saturation.
Professor Hart, what is the practice in the UK?
So I think this is a really important area because it actually empowers patients to understand when they should be seeking medical help. And I think Randy made an important point earlier that this is a highly infectious virus and the households will have to look after themselves because of isolation. So those living in the same household, which is exactly the experience I had. I was somebody who contracted COVID at the end of November, the beginning of December. And during that time, I was looking out for the clinical red flags, which were important. Clinical red flags of breathlessness when you're walking to the toilet, breathlessness when you're walking upstairs, breathlessness when you're lying in bed. All of these have escalating importance. And I think if you're breathless at rest, lying in bed, you should be seeking medical attention. If you're walking to the toilet or walking upstairs, your recovery time is over 2 minutes, you should be seeking medical attention. In the UK, we didn't rely on pulse oximetry necessarily by the patient themselves. We actually use that in terms of healthcare professionals, because I think it's often very difficult with this condition, which does have variation in oxygen saturation. And as Randy says, when you hit a particular, we use 94%, 92%, it becomes a major issue. And if you're measuring oxygen saturations, I'd be doing a sit to stand over a minute, which is what we did. And we saw a reduction in 90 to 93% or below, or a reduction of 3% from baseline. So those of tests to understand whether people are in a significant condition are clear. But breathlessness on walking to the toilet, walking upstairs, or lying in bed are really key elements that show the escalation of problems. Randy is absolutely right. Diabetes out of control became a major issue and has been a major issue even after we've got through the second wave. Ongoing fevers, more than 72 hours of persistent fever, I think is a significant problem, especially for patients who are perhaps not keeping up with rehydration, drinking, and so because they're unwell. And in those elderly patients, delirium. We saw significant delirium in the elderly population, that ability where they weren't quite making sense. I think, again, that prompts you to say, this is a red flag. you will need medical help. You will need to go to the hospital or seek medical attention.
In the hospital itself, there have been so many advances over the last 1 year in terms of the treatment protocols to a number of completed clinical trials, many of which were conducted in the UK. So what are the key areas of medical treatment that should be provided in the hospital in order to save lives?
The way we approached the treatment of patients as they came through the front door in the hospital was by using evidence that we gained from wave 1, from the clinical trials, and we actually set this up between the waves. So we had the big 5 that we rolled out across our institution. This is simple and deliverable. Obviously, part of the big 5 is maintaining fluid balance an equivocal state. We do not want patients dry and we do not want patients wet. Not good for the kidneys and not good for the lungs. We obviously want to treat patients with oxygen therapy when they require it. We need to make sure those requiring oxygen therapy receive corticosteroids, and recovery has taught us that dexamethasone works in order to use the virally triggered immune inflammatory response, and it reduces that inflammation. We also used antivirals. We use remdesivir, and this is guided by the chief medical officer in terms of support for patients with COVID-19 who are hospitalized requiring oxygen. It's important to highlight as a red clinical flag again that patients will present at 7 to 10 days, and they need to understand that their risk period is between that time. In fact, when the virus has come down, but the inflammatory response is rising. And so the use of remdesivir is actually up for discussion, but it's still currently used. The final part of the big 5 is anticoagulation. We know that the endotheliitis, the increased risk of blood clots that we saw during the first wave, can be reduced by the prophylactic use and protracted use after discharge of anticoagulation therapy. So a standardized, clear approach, which has patient-centered care at the focus, will allow you to provide care to significant numbers of patients, but in a very, very standardized fashion.
Professor Guleria, we haven't heard the word ventilator yet, and that was the word that dominated the headlines and the pictures last year. Obviously, there have been very many changes in the treatment protocols. What are the protocols that you would recommend in India?
So in India, we're looking at, as we mentioned, this viral infection as being a biphasic illness. The first phase being when you have excessive viral replication, followed by a stage when you have a dysregulated immune system and a hyperinflammatory sort of syndrome happening. So and we probably divide into 3 stages. In the first stage, which is the mild stage, we usually follow home isolation and symptomatic treatment. In the second stage is then the patients start coming into hospital. That's when your saturation is falling. It's usually the 5th to 7th day, and you are actually now having features to suggest that this virus is now going down into your lower respiratory tract. There are 3 things that we focus on predominantly as the standard of care. One is oxygen therapy, and we really focus on trying to give oxygen to maintain your saturation between around 94. If that doesn't work, we do aggressive conscious proning, and then you have other ways of trying to improve oxygenation, like the high flow nasal cannula if that is required, or a non-invasive ventilation. The second important thing that we focus on is basically the use of steroids. And as has already been said, there is now enough data that in this group of patients, when you have a moderate illness with falling saturation, that steroids do decrease mortality. And steroids are used, we use both dexamethasone, and some centers will also use methylprednisolone, depending upon the availability. The third pillar that we focus predominantly on is on anticoagulants. And we would give a prophylactic or a semi-therapeutic dose of anticoagulants to most of our patients who come in, because we know that this virus causes a systemic effect which can lead to a hypercoagulable state. The other things that we recommend, although these are not the main pillars, is the use of remdesivir early in the disease, and remdesivir is used for about 5 days in the disease process as per the guidelines. And also, although that has now been removed today, we would also advise that convalescent plasma, which had high titers, could also be considered in some patients in the early stage. In the third phase, and there's a very small number of individuals who would go on to the third phase, where you are having your biomarkers and the requirement of oxygen becoming very high, and features to suggest a hyperinflammatory syndrome. In a very small number of patients, anti-IL-6 drugs like tocilizumab has also been used. But I think the focus of our treatment has been the main three that I mentioned: oxygen, steroids, anticoagulants, and as was mentioned, making sure that the intake output is maintained and you're well hydrated in terms of your kidney perfusion. So this forms the basic strategy as far as treatment is concerned. It's only in a small percentage, and I think the data from our country suggests that it could be just around 2% or 3% at most, that you really need ventilatory support and you need invasive ventilation.
Whether treated at home, as most of them should be, or managed in the hospital, as some of them will require, most people do recover. However, some of them seem to carry the burden of long-term symptoms and sequelae, what's come to be known as the long COVID. What's your experience in the UK with this problem, and how are you handling it and counseling the people who report symptoms for several weeks or months?
Srinath, that's a really important question. We, like many others, have had two very significant waves of acute COVID. And I think it's, first of all, we need to understand the categorization of COVID. And that is that we have acute COVID, we have post-acute COVID, the soliloquy of COVID, and long COVID. And the reason I think we need to think about four categories is because acute COVID, well, we all know what that is, and that can be mild, moderate, severe, treated at the home or in the hospital. We then think of the post-acute COVID, which is the period up to 12 weeks where people may have ongoing symptoms. We then have the soliloquy of COVID, which is those patients who suffered acute lung injury, myocardial injury, liver injury, but mainly around the lung injury that people suffered and then have persistent changes in terms of fibrotic change within their lungs. The long COVID condition, as we're seeing in the UK, are those patients who weren't admitted to hospital, who had mild to moderate disease and had that at home. These patients have persistent symptoms at 3 months, over 3 months. And so that's the very clear definition we're using. If you have persistent symptoms more than 3 months, the main symptoms you'll see are fatigue and breathlessness. There will be other symptoms such as brain fog, muscle aches and pains, joint aches and pains, insomnia. But the main symptoms we're seeing are breathlessness and fatigue. The breathlessness and fatigue that we're seeing associated do not have significant abnormality related to their imaging or their tests, their lung function tests. In fact, it appears there is a psychophysiological imbalance that is occurring. These patients have become significantly deconditioned. And so we're setting out a holistic, patient-centered program, multidisciplinary approach using therapy-led but medically supported services in order to provide a better outcome for these patients.
Professor Guleria, our waves started later than in the UK. In fact, they started cresting when the UK waves had subsided. What is our experience with the long COVID?
So after the first wave, we had also started seeing a lot of post-COVID sequelae. We use the same criteria that up to 12 weeks was post-COVID and more than 12 weeks was long COVID. And we did see many patients in our hospital. In many hospitals, we formed a post-COVID clinic, which we were running till we had this huge surge as far as second wave was concerned. And because of the lockdown, this had to be stopped, although we still continue with teleconsultations. But we did see many patients who had what we call chronic fatigue syndrome, fatigue, body aches, lethargy, not being able to go back to work as much as they would like to do. We also have patients who have the so-called brain fog. And of course, for us, for me actually, and being a pulmonologist, we do see a number of patients who have long COVID with lung fibrosis. There has been a lot of debate in our pulmonary circles in terms of how to manage these patients. Should we continue steroids for a longer period of time because of the fibrosis in the lung, which is persisting? Should antifibrotic drugs like nintedanib or pirfenidone be given? We focus a lot on pulmonary rehabilitation, and that seems to be the best way that it works. I think that this fibrosis is different from what we see as part of what we would see with, say, connective tissue disorders or idiopathic pulmonary fibrosis. And in many patients, it will resolve on its own, both in terms of the lung function, in terms of the CT scan, and focus is predominantly on pulmonary rehabilitation and getting them to really start doing some degree of exercise, which helps both from the systemic point of view and from the lung point of view. But this is a big problem that we anticipate we will see in the coming months, because as COVID sort of wanes, the number of patients who will have a post-COVID sequelae or long COVID will actually continue, and they would need care, and this is going to be substantial.
Well, thank you very much. Let's hope that we will be able to beat the virus, at least in terms of the severe effects on health that it seems to be having in different parts of the world. So that if the only problem that we have to deal with is the long COVID later on, then I think we should consider ourselves fairly successful in our initial fight. I would like to thank Professor Nicholas Hart and Professor Randeep Guleria for sharing their expertise and experience with COVID. And I would also like to thank Mr. Uday Khemka for having conceived and catalyzed this conversation. Thank you very much.